Assalamu alaikum wa rahmatullahi wa barakatuh. Hello everyone and welcome to one of our free sessions in which we are going to discuss some questions related to maternal medicine. Inshallah, we are going to cover as much as we can, and I'm so sorry for my voice. I'm having very terrible laryngitis and I'm trying my best to make my voice clear. So, is it clear for you? Hello, Dr. Malikam, how are you? Okay, shall we start? Yes, please. Okay, and we are going to start with the first question. And I have chosen some questions that are different from the one that you have answered through the Facebook group or the Telegram group. Hopefully, they are going to be beneficial, inshallah. So, what do you think? I'm not going to speak out the question because this is going to stress over my vocal cords. So, if one of you wanna say out loud the question, I would be very thankful. If you are okay, okay, I got some answers. That's great, and we want to know why, because this question can come in different phases. Like for example, they can bring you a woman with a history of atrial regurg, for example, atrial regurg. So, what do you think would be the main cardiac issue for someone who has atrial regurg? Not one of those, by the way. Not one of those. I can give you another options, but this was a recall. Not the same as this one, but the idea. Okay, Dr. Khan, I prefer Khan. Dr. Khan, I would answer pulmonary hypertension if the tetralogy of Fallot was not repaired. But this one was repaired in childhood. So now we are thinking of another thing that can happen specifically during pregnancy, which is, yeah, like many of you have answered, right ventricular dysfunction. Yes, this is the correct answer. Why? Because there is some sort of pulmonary regurg that can happen even after the correction or the correcting surgery. Pulmonary hypertension should not be there because the aim of the correction surgery for Fallot is to reduce the pulmonary hypertension, right? The question again that the patient is having a history of tetralogy of Fallot and she had a repair surgery during childhood. What would be the main cardiac issue that she can potentially face during pregnancy? I asked you another question, and it was a recall one. And unfortunately, guys, I know cardiac diseases are somehow tricky because they are so many. And unfortunately, one of the recall questions came directly from the European guideline. And this is too much. This is too much for us as a obstetrician to go through all diseases. So at least you should know the common valvular conditions or the common congenital conditions, the main symptom, the main complication, uh, how I would treat her specifically during pregnancy if there is any something specific to the disease. Like, for example, I asked you now if the woman is having a history of atrial regurg, okay, and she's very prone to have atrial fibrillation from time to time, what would be the main cardiac issue during pregnancy? By the way, atrial fibrillation is also very well tolerated during pregnancy, but there is only one problem that can happen with atrial fibrillation or let's say mitral regurg. for example. So we are having atrial thrombi. The problem of having atrial thrombus. This is the problem. So this patient is going to need definitely low molecular weight heparin. So think about it. Anything that can cause pulmonary hypertension or atrial thrombus. This is the cardiac main issue. This is our main issue. Why so? Because if we are having a pulmonary hypertension, severe one, this woman is going to be advocated to become pregnant or not. No, of course. And this is the whole idea. This is the whole idea. Another one is if the patient is having recurrent atrial fibrillation, okay, because of whatever condition that can lead to atrial fibrillation. This woman is very prone to make atrial thrombi, and those atrial thrombi can travel, right, and occlude any vessels. Most importantly, the pulmonary vessels or the cerebral vessels. Okay, here we are having a case of Eisenmenger. See, I told you we don't need to be cardiologists, but at least we should know the most severe cardiac condition. Yes, you are definitely right. Termination of pregnancy. Yes, Eisenmenger syndrome is not advocated for pregnancy whatsoever. Yes, and if we are going to give her an advice about contraception, what would be the best? This is exam question, by the way. What would be the best contraception for someone like her? Implant is LARC, but there is something much better than the implant also. Sterilization, yeah, she can have sterilization. She can have DEMPA. She can have the implant, of course. All of them are LARCs, right? Regarding the best contraception in means of the best one in or the least one in failure, it would be the subdermal implant, of course. But if we are talking about the best contraception in means of continuity, this would be Mirena. Okay, because many patients are going to stop the DEMPA and they are going to stop the Nexaplanon. Do you know why? Because of the side effects. So there is high rate of discontinuation, although the implant offers us the best coverage, the safest contraception ever is the implant. 0.05% risk of failure only. So this is the best, yes, but it's not the best for continuation. Okay, so if you are going to think of one, if this is a question, I would go for Mirena in those cases first. Because of the compliance. I want the best compliance. The best compliance is with Mirena. DEMPA is really good, the implant is perfect, but the compliance with them is not really good. And the rate of discontinuation is somehow higher than the Mirena. Yeah, in the hospital, of course. Yes, okay. What about this one? Very typical exam question. Do you remember when I told you our college need some sort of things? to examine us about. Number one, what would be the first line investigation for most of the diseases? Number two, what would be the best next step? They love this question. Number three, what would be the gold standard investigation? By the way, gold standard investigation, it is not the same like first line investigation. Okay, so here we are. And I'm having different answers and I like it. I'm having a patient here with sudden onset acute pain. Okay, it's radiating to the shoulder and arm. What you are expecting, guys? What do you want to exclude? This is how you should think. Yes, acute MI. Acute MI. So what are you going to perform to exclude the acute MI? ECG. Yeah, this simple. This simple. What about troponin? Troponin is good, but it's not the first line investigation. No, never. You know why? Troponin can change. And yes, excellent, Dr. Farah. It's going to take like 12 hours to peak. Number two, sometimes the level of troponin is going to be altered by uh, like eclampsia, for example, preeclampsia, hypertension. Okay, even if there is no significant cardiac disorder. So I cannot depend on troponin as a first line investigation. But, and I'm not sure I have included this question or not. If they ask me about the biomarker or the cardiac biomarker of choice for diagnosing MI in pregnancy, which one you are going to choose? Troponin or other biomarkers? Yes, troponin, not PNB. Troponin. Okay? Yeah, it can change. And yeah, it can be affected by other conditions, but still is the one that cannot be high if the woman is normal. Troponin levels during pregnancy should be normal. Even if it's a little bit high, it's not going to be above the upper limit. Okay, let me ask you another question. What would be the most specific ECG marker for acute MI? The previous question I asked, it was what would be the best cardiac biomarker to detect acute MI in pregnancy? This is troponin. Now I'm asking you, what would be the most specific ECG marker to diagnose acute MI? This is also a recall. Yes, ST elevation. Excellent. Excellent. Okay, this one is very recent. This question is very recent. We are asking here about the leading overall single cause of maternal death. According to the latest Embrace report, 2022. So I guess you have not read 2022 report. Cardiac diseases was the leading overall single cause of maternal death in UK from 218 to 2020. Excellent, Dr. Laila. Now, I don't know who is iPhone. Now it's thromboembolism. Again, we are back to thromboembolism. And I love this question, guys, because it differs someone who is updated from someone who just rely on the questions in the book or the recalls or within the groups. This is the latest Embrace report, I'm sorry. And they are telling us that thrombosis and thromboembolism is coming back as the leading cause of maternal death. The next one would be COVID-19. Take care because they can ask the following questions. What would be the next most common direct cause of death after thrombosis and thromboembolism? You can cheat. I'm going to repeat the question again, and I'm so sorry for my voice. What would be the next most common direct cause of maternal death after thrombosis and thromboembolism? Suicide and sepsis. Suicide and sepsis due to pregnancy-related infections, not outside pregnancy-related infections. Suicide and sepsis due to pregnancy-related infection. Here they said direct cause. Okay, this if she's having the COVID during pregnancy, and for some reason she went into sepsis, which is very, very weird, by the way. COVID-19 usually does not cause sepsis, it causes pneumonia and VTE. One of the most common complications of COVID-19 during pregnancy is VTE. Yes, both together. Suicide and sepsis due to pregnancy-related infections both comes next to thrombosis and thromboembolism as direct causes. As direct causes. After COVID-19, the next leading indirect causes were cardiac disease and neurological conditions. Both now are equal. I hope, I wish I would get you the graph, but anyway, you can find it in the Telegram groups. I can reshare it anyway. They are having very similar numbers now, almost equal. Okay, so here indirect causes, mainly the COVID, because the COVID usually the mother is going to contract before getting pregnant, and then because of the low immunity during pregnancy, she's going to die because of the COVID-19. This is why it's a leading indirect cause. But overall, and take care of the question, guys. If they are saying the leading overall, or they are saying the leading direct, or the leading indirect. Leading overall now is thromboembolism. Comes next, COVID-19. Okay? Is it clear now? Because it's because of pregnancy, Dr. Kulsoom. It's because of pregnancy, not because of psychological disorder while she was non-pregnant. This is why it's considered as a direct cause. Like, for example, a woman who did suicide after having postpartum depression or postpartum psychosis. And by the way, guys, postpartum depression is not only postpartum. It can happen antepartum also. It can occur from the second trimester. Or if the woman is very liable or had um, postpartum depression in the recent pregnancy, from the latest pregnancy, she can have depression again in this current pregnancy very early. The recurrence can be very early. So yeah, she can have depression during pregnancy and then commit suicide after labor or even during pregnancy, who knows? And it's really difficult, by the way, and they really focus on it. And this is why we are having a new talk article about the psychological medications and different mood stabilizers, and so on. Because suicide, still until now, the most common cause of direct death, direct maternal death during puerperium. Okay, Dr. Farah is saying thromboembolism, first direct, suicide and sepsis, second direct, COVID, first indirect, cardiac and neurological disorders, second indirect. Yes, you are correct. Now, this is also new because before, during, or up to 6 weeks after the end of pregnancy, the most common cause of death was suicide. Now, again, thrombosis and thromboembolism are the leading cause of maternal deaths. COVID, the second most common one, followed by cardiac diseases and mental health related causes. So now we are having the mental health related causes and cardiac disease on the same scale. So it's different. It's different now, which means they have managed to correctly diagnose many cases of mental issues, correctly treat them, but still we have a problem with the VTE, and we still have a problem with some cardiac disorders, right? This is why thrombosis and thromboembolism become the first again. Okay. Yeah, okay. This one is tricky, so take your time thinking about it. It's a strategy question. This woman is diabetic, Asian, acute onset epigastric pain, chest pain, breathless, third trimester, gravida 5, BMI over 40, poorly controlled diabetes, anemic. Wow, what a history. She is on oral iron, and there is history of familial hyperlipidemia. Don't underestimate this. Don't underestimate this. She's having a history of familial hyperlipidemia plus being morbidly obese, poorly controlled diabetes. What is the most likely working diagnosis? Working diagnosis means the one that you should exclude, and then it can be any other thing. Can be any other thing. So what do you think? Acute chest syndrome is not here. Okay, I'm having pulmonary embolism, and I'm having MI. Okay. Okay, you mean acute coronary syndrome? I wish it was here. Okay, most likely working diagnosis means, as I told you, I want to exclude something, and then I can run another investigations to make sure that is this MI or other thing. This is very important, very tricky, very tricky. This woman is at high risk for having acute MI or acute coronary syndrome. Excellent, Dr. Laila. This is what should you think about at first. Then it's very easy to exclude MI. Only ECG can exclude MI, right? So this is the most likely working diagnosis. This is what we mean by working diagnosis. So here, the symptoms are leading us to acute MI. Then I'm going to do further tests to see if this is really acute MI or not. Okay, I think we had this before, but yes, troponin. Yes, this is the blood marker of choice for diagnosing acute MI in pregnancy. Not BMB, not C-reactive protein, not creatinine kinase MB. The second would be PMP, but PMP usually we do it for heart failure, and it's not very specific. Let's go for troponin now. If it's very high, above the upper limit, with suspicious ECG, this is your diagnosis for AMI. Okay, following diagnosis of acute MI, which medication should not be used in acute phase? Who has attended the session for hypertension with me before? Excellent, excellent. I'm so proud of you. Yes, nifedipine is contraindicated in acute cardiac conditions. Whether it was severe or emergency preeclampsia, or you are suspecting acute heart failure, or you are suspecting acute MI, nifedipine is not our friend here. Excellent, guys. Okay. Just to break the mode of cardiac disease, and we are going to get back to some more questions. What do you think of this case? This case is a hypothyroid case. But by the way, this is a daily antenatal care case. Okay, because hypothyroidism is not uncommon in pregnancy. It happens like 0.5% of pregnant ladies are going to be hypothyroid. The subclinical hypothyroidism, if I'm not wrong, it makes like 2.5%. Here, the woman is taking levothyroxine 100 micrograms once a day. And we had the thyroid function test. It was TSH 2.5. Okay, now she's pregnant. 2.5 is okay to you or not okay? Who can tell me? Let's take it step by step. Yeah, it's normal. The lower limit is 0.1, the upper limit for first trimester, 2.5 or 3. Don't rush, don't rush. Just tell me the lower limit and the upper limit for TSH. Upper limit for the first trimester is 3. Okay. So here, for the first trimester, yes, excellent. 0.1 to 2.5. In the second and third trimester, the upper limit would be up to 3. Right? Great. But we have a general rule. We have a general rule. Because of the demand or the increased demand of the levothyroxine during the first trimester specifically, because the fetus depend mainly on the maternal levothyroxine. So we are going to increase the dose by 25 micrograms. This is a general rule. And then we are going to do a follow-up test. If she needed more, we are going to give her more. If she is okay, she can continue on this dose all through pregnancy if she is fine with it. Okay? And we are going to titrate the dose according to the results. But remember this, guys. The baby depends mainly on the T3 of his mother. He cannot do it by himself in the first trimester. The thyroid is immature yet. Okay, so this is why we are going to give her more levothyroxine. So starting dose to increase is 25. So now she's going to take 125 according to this case. Then I'm going to run some thyroid tests for monitoring. By the way, this is exam question. It's a recent recall also. How you are going to monitor a lady with hypothyroidism after whether she was hypothyroid before pregnancy or she's now diagnosed as hypothyroid and she started taking medication. So I'm going to do a test after 4 weeks from the first dose, and then every 4 to 6 weeks, titrate the dose accordingly. Okay? If she is controlled, how often you are going to do the thyroid function test? This is a recall also. It's eMRCOG, by the way. Suppose the woman is taking levothyroxine. Okay, you have monitored her. She is well controlled, excellent. I'm going to run the thyroid function test every trimester, once in each trimester, not every 4 to 6 weeks. When the level is not optimized, I'm going to titrate the dose and again follow up her every 4 weeks. Right? Don't forget that this woman needs a checkup 6 weeks postpartum. Usually she's going to get back or return to her pre-pregnancy dose. Okay? Once normal, you are going to do, yes, the checkup labs once every trimester. Those are definite recalls. Definite recalls, guys. The follow up, okay? The follow up after taking the medication and the follow up once she is optimized. This is a question, and this one is another question. Now, another recall question, which is really, really good. If the woman is going to have a radioactive iodine, and you know that this is contraindicated during pregnancy, we can do thyroidectomy during pregnancy. We can have medications during pregnancy, but we cannot have radioactive iodine. How long should she avoid pregnancy after taking radioactive iodine? Yeah, you have to remember this by heart. Is it 3 months or 6 months? At least what? Yes, at least 6 months is excellent. Excellent, excellent. I was trying to. to see if you are having solid information or not. Yes, you are right, guys. 6 months is excellent. And I have mine, but you should have your own note when to stop this drug before getting pregnant. Whether it was radioactive iodine, whether it was methotrexate, whether it was IPD medications or biological agents, when the woman should delay pregnancy if she's having bariatric surgery. Questions like this are very familiar in the exam. Okay, this one is easy, but we're going to talk a little bit more about biological agents. Okay, you remember the top article about IPD and biologic drugs? It's all about the drugs. I consider this top article a pharmacological top article. Which one is contraindicated in pregnancy? Which one is safe during pregnancy? Which one is safe during breastfeeding? Which one should be stopped before labor and by how many weeks? What are uh, what are the safety measures that you should tell the patient about if she was taking biologic agents during pregnancy? Here, the woman is taking many things. Let's go through one by one. She's taking prednisolone. Safe or not safe? Safe. Mycophenolate for MMF. Unsafe. Pregnancy only or breastfeeding also? Both of them. Excellent. Okay, ACE inhibitors because she's hypertensive, of course. She's having chronic renal failure. Unsafe. Aspirin. Safe. Okay. So now we know which one is going to be stopped, and we wanna substitute them. She's going to continue on prednisolone. You are going to substitute the mycophenolate. Choose one of choose one of them as a substitution to mycophenolate. Which one of those? I would go for azathioprine, honestly. No, I'm not asking the question now. I'm asking if I want to substitute mycophenolate with another agent. Which one you would choose from the choices here? Azathioprine. Yeah, I would go for azathioprine because it's have a safe profile. Then cyclosporins. Okay. If I wanna substitute the ACE inhibitors to control the hypertension, which is a result of her chronic renal failure, what agent you are going to give her instead? MashaAllah, quick answer. Labetalol. Labetalol. Labetalol first, Dr. Khan. Don't think about nifedipine unless in the postpartum period, and especially for the Asian or African stenosis. Or if labetalol is contraindicated, yes, like as your colleague are saying, like asthma, for example, she cannot take beta blockers, but our first drug of choice is labetalol. You mean nifedipine in pregnancy? Nifedipine is a first-line antihypertensive drug during pregnancy only if labetalol is contraindicated, according to the NICE guideline. Okay, so here I have seen your answers. Azathioprine is safe, cyclosporins are safe, hydroxychloroquine is safe, tacrolimus is safe. So the only one that would be contraindicated in pregnancy is sirolimus. Yes, you are right. All of you, you were right. Um, maybe I don't know outside of pregnancy what would it be, but inside pregnancy and according to the NICE guideline, labetalol is the first one. Whether she was chronic hypertension, gestational hypertension, any kind of hypertension. Any of you remember what would be the most common side effects of chronic use of labetalol or beta blockers during pregnancy? You mean small for gestational age? Yes, small for gestational age or FGR. Yeah. This is, by the way, can be an exam question, especially that we have a new guideline talking about FGR. The chronic use of beta blockers, chronic use, not the use of beta blockers only during pregnancy. If she is on long-term beta blockers, this can lead to SGA of the baby. Yes. Okay. We come back to some endocrinological cases. So try to think about it here. This woman with type 1 diabetes attends for the pre-meeting 6 weeks after delivery. This is the usual meeting for chronic illnesses. As she had a difficult delivery, she's complaining of tiredness. Okay, if I were you, I would do this in the exam. The neonate has not taken to breastfeeding. The woman has noted involution of her breast. She's not anemic. Thyroid function test showed a T4 of 8. 8 is normal. TSH is high. This is high. Okay, so now if I'm in the exam, if I were you, okay, with the stress and everything, I would think of hypothyroidism, right? But uh, have another look. Have another look on the scenario and have another look here. 8 is normal. One of the most pathognomonic features of Sheehan syndrome or the avascular necrosis of pituitary is the inability to breastfeed. This is like a red alarm for Sheehan syndrome. Before anything else can happen, the failure to lactate. But guess what? In real life, this only happens in acute Sheehan syndrome. Yeah, definitely, Dr. Farah. Sheehan syndrome, I used to believe once upon a time that Sheehan syndrome has something to do with the severity of bleeding. Guess what? It has nothing to do with the severity of bleeding. It's just a variation between a woman and another woman. This woman, pituitary, didn't hold the amount of blood that was shed during labor or even postpartum period. Yes, even she didn't have any kind of hemorrhage. And in this case, it's not acute presentation. She can present several months after labor. She's going to develop some symptoms that are not related to each other. Yeah, or even after 6 weeks. Even after 6 weeks. And this is for you, okay, not for the exam, because they are not common. There is something called partial Sheehan syndrome, which is very tricky to diagnose, in which only a part of the pituitary is necrotic while the other part is working. So, according to which part is affected, she can have a problem with the menses if the FSH and the LH are not secreted well. She can have a problem with the prolactin and the breastfeeding, or she can breastfeed normally, but the ACTH and the growth hormone are affected, and so on. Here, this is a typical case of Sheehan syndrome. A typical case would be complaining of tiredness. The TSH is going to increase at first, trying to work more because of the tiredness, because of the disrupted metabolism, not because of the pituitary necrosis. It's very complex, very tricky. Okay, and if we do another test for this lady, we are going to find that the other hormones are low. But by the way, you can face such cases in real life, but you are not going to diagnose them unless you are having a complete hormonal profile. Almost impossible to diagnose a case of atypical Sheehan syndrome or a partial Sheehan syndrome, and she's not going to come to you. She's going for endocrinologist or internal medicine. She will be always tired. She will be always fatigued. Some cases are going to have disturbance in other hormones, so it's going to affect their libido, it's going to affect their menses, it's going to affect their weight, because it's complex. The hormonal cycle, all of it is disturbed. When you disturb the thyroid function in any woman, it's not only going to be like the TSH is low and the T3 is going to be high. No, we are talking about cortisol is going to be secreted to make sure that the body is holding up itself, coming up together. Cortisol is going to be secreted. Cortisol is going to affect the sexual hormones. Sexual hormones are going to be disturbed, so it's going to affect the libido and it's going to affect the body hair. It's a cycle, a whole cycle. In this case, they did another biochemical analysis and it came up again with increased TSH concentrations, but gonadotropin deficiency, decreased insulin growth factor, which is it's like insulin tolerance test. It's a marker for growth hormone. The free urinary cortisol concentration is at the bottom line of the normal range. So that means that ACTH is also low. And in conclusion, the MRI showed empty cell. So the pituitary tissue is now almost necrotic. I'm telling you, this is a typical case. And it has nothing to do with the amount of bleeding. Yes, Dr. Kulsum. Yes, if it's a typical Sheehan syndrome, everything, pan hypopituitarism, everything is going to be low. Growth hormone low. We do insulin tolerance test to detect it. The TSH is not the first thing to look for. Okay, it's not the first thing to look for. To look for the gonadotropin, look for the prolactin, look for the ACTH. Those are going to give you a clear image. Is this patient is really having Sheehan syndrome or not? You know why? Because again, maybe the TSH is trying to increase in secretion as a result of the disturbed metabolism. Atypical cases are rare in life, and they are not going to be diagnosed that easily after they birth. It's going to take them months or even a year before she get a clear diagnosis. Okay, here we are with adrenal disorders in pregnancy, and I know it's not your favorite. I know it's not the cup of tea for everyone. But you should know adrenal insufficiency. If you are not going to study anything, please go for adrenal insufficiency. We're having a woman here, and she's having a history of adrenal insufficiency. What you are going to do with her during labor, before going through the options, before going through all this, which is intimidating, honestly. I'm looking for what? I'm looking for continuation of the usual dose or increasing her dose or what? Yes, I'm looking for an option that give me addition of a stress dose. Excellent. So at least I'm going to exclude some of them because I feel very stressful when I see options like this. So I'm going to exclude some of them so I can have a clear image. This one is not going to work. This one, increase dose. There is no addition. Okay, I'm going to leave it now. Increase, no addition. There is addition here, addition here, addition here. Um, I'm not sure what they did here. They omitted her usual dose and only give hydrocortisone. So maybe you are better than me. If anyone got the chance to know the correct answer? Okay, I'm having G, hydrocortisone, 100 milligram IM, 6 hourly for 24 hours, then reduce to maintenance over 72 hours. It's not incorrect, but maybe there is something better. Mm, yeah, yeah. What about the continuation of the regular oral steroids and the addition of hydrocortisone, IM or IV, but we want the correct dose, and the correct dose would be 100, of course. We want a total of 200 on Labor Day, divided on 2 doses or 4 doses, whatever you like. So we want 200 milligrams. at least. Honestly, those options are painful to my eye. Okay, so we are between D and E. And actually, Dr. Farah, you are correct. It's D because I need 200 milligram of hydrocortisone. So if we calculated, it would be hydrocortisone 50 milligram, whether it was IM or IV, every 6 hours in labor until 6 hours after the baby's born. Then we are going to see what we are going to do. But this is the stress dose, guys. This is the stress dose. We are going to continue on the regular oral steroids. Do you remember this? I told you before, this one is crucial. On the delivery day, we are going to give 200 milligram in the labor day. Okay? Here in the talk article, they preferred to give the hydrocortisone IV or oral. Maybe she's going to have a normal vaginal delivery, so she's not having IV line or whatever. But the most important thing is that we are going to hold the fludrocortisone if she's taking one. Okay, if she's taking one, we are going to hold it. This is the most important thing. Then at day one postnatal, we are going to divide the dose into half. So she's going to have only 100 milligram per day. Still, I'm not giving the fludrocortisone. Day two postnatal or day three, starting delivery. Cut it into half. Give 50 milligram per day. Again, I'm still holding the fludrocortisone. This is the mineralocorticoid. I don't want it now. On discharge, on day four or day three postnatal, I'm going to give her approximately the usual dose she's taking, or maybe it's a little bit higher than her usual dose, but 30 to 35 milligram per day or anything less than 40 is very easy to accept and tolerate, and we can decrease it if we want with her endocrinologist. I don't care. Okay, but for this, those are the most stressful days. So I'm going to cover her with the appropriate amount of hydrocortisone. And by day four, I'm going to restart the fludrocortisone back if she is taking it. Take care that some women don't need mineralocorticoids. They are okay only with glucocorticoids. Not all people are having Addison. Some of them are having adrenocortical insufficiency. So they only need glucocorticoid. They do not need mineralocorticoids. This is for you, okay? Forget about the exam. The follow-up is going to be with the endocrinologist. He's going to take care of her. He's going to titrate the dose until they reach a good cortisol level without side effects, because cortisol is having horrible side effects. So if she is hypertensive or she is becoming diabetic or her blood glucose is getting higher, he's going to titrate her dose until all of this go away. Okay, this is for someone who's having adrenal insufficiency during labor or a stressful event. What about someone who's having adrenal crisis? She's not having a usual adrenal insufficiency, so take care of the doses here. The doses are different. This woman needs ABC. She's dying. ABC, airway, breathing, circulation, white pore cannula. Take blood samples. See the ACT action cortisol. If she's not taking cortisol, because if you are going to do ACT action cortisol while the woman is already taking cortisol, then forgive me, you are crazy. Of course, the ACT action is going to be suppressed. But if the woman is having adrenal crisis and you have no idea that this woman is having history of adrenal insufficiency, then yeah, we need to run ACT action cortisol. This is what we call primary adrenal insufficiency during pregnancy. She has no idea that she is Addison. She has no idea that she's having adrenal insufficiency. But out of the blue, she collapsed on the table. The anesthesiologist is telling you the woman is having severe hypotension. Okay, but her heart comes back quickly. But severe hypotension, severe hypoglycemia. Her oxygen saturation is going down. He is suspecting adrenal crisis. This is what we should do. We should administer 2 to 3 liters of saline or 5 dextrose saline. Again, we are dealing a shock. We are dealing with a shock, like a shock. And we are going to give her intravenous hydrocortisone 100, the whole ampoule. The ampoule is 100, so we are going to give her the whole ampoule. The whole ampoule every 6 to 8 hours. Or if you are having a continuous infusion, it would be calculated according to the whole day, 200 to 300 milligrams per 24 hours. Usually this is going to be done in the ICU. So just remember, a woman need a stress dose. It means 50 milligram every 6 hours. In total, I want 200 milligram per day. A woman with adrenal crisis, she's going to need 100 milligram every 6 hours. So it's double the dose. Okay, guys, that's it. This is the difference between this woman and this woman. Systemic lupus flare. Yeah, if she is on corticosteroids, yes, definitely. Any woman who is taking corticosteroids. Thank you, Dr. Farah. This is good question, very good question. Any woman who is taking chronic corticosteroids, she is liable to have adrenal crisis during stressful events. And yes, she needs to be covered with a stress dose during labor, during cesarean section, during severe postpartum hemorrhage, any stressful event, during trauma, anything. Thank you, Dr. Farah. Excellent question. Because I'm just focusing now on adrenal disorders. I forgot about the others. Okay, so this one, I think it's now easy. The same like the previous question. If you are having a planned cesarean section, same answer. But what about this woman? Sorry. This woman is having adrenal insufficiency again. She is coming to you in the antenatal care clinic. What you are going to do with her pre-pregnancy steroids? Is it like thyroid disorders? Are we going to increase the dose of cortisol or no need? simply. Do you think we need to increase the dose of cortisol during pregnancy? Remember the physiology. Remember the physiology of pregnancy. What about cortisol levels during pregnancy? In a normal pregnant lady, is it going to decrease or increase? Pregnancy itself is not a stressful condition. Yes, the placenta is secreting cortisol. Placenta is secreting cortisol already. And this is something very fortunate to us. Why? Because I'm not going to increase her dose. If she was controlled on 5, she can continue on 5. If she was controlled on 10, she can continue on 10. If she was taking only hydrocortisone, she can continue on it. So now it's very easy, not like the thyroid disorder. Right? Continue fludrocortisone and hydrocortisone as per pre-pregnancy. Whatever it was. Whatever it was. She was taking 20, she was taking 10, she was taking 30. I don't care. Okay, now another question that comes to my mind now. If the woman is having congenital adrenal hyperplasia, okay, and you know that the most common type, they are going to have cortisol deficiency. Which type of cortisol you are going to use during pregnancy? Are you going to use dexamethasone or hydrocortisone? Yes, excellent. Never use dexamethasone to make up for low cortisol during pregnancy. We only use DEXA as a short term for antenatal steroids for lung maturation. Yes, excellent. But hydrocortisone is your best friend. If it's not available, she can take prednisolone. Excellent, guys. Okay, back again to thyroid. I think this one is really easy. Anyone tell me if this woman is hypo or hyper, please? From the labs, hyper. Okay, the most common cause of hyperthyroidism in pregnancy is Graves' disease. Excellent, excellent. Okay, this woman is already diagnosed, right? We already know that she is having a Graves' disease. She has radioiodine therapy. Okay, everything is good. So when we need to do a follow-up for her, we did the TSH and free T4 and free T3. If a woman is having Graves' disease symptoms during pregnancy in the first trimester, do you think to make a definite diagnosis for Graves' disease, you are going to depend on the TSH? She does not know. She got the symptoms during the first trimester for the first time. Yes, I'm not going to depend on TSH to make a definite diagnosis. I'm going for the antibodies. Excellent, guys. Excellent, guys. So option D, check thyroid stimulating antibodies trap. not TPO. TPO is for Hashimoto or hypothyroidism. Before commencing antithyroid medication, this would be correct answer for someone firstly or suspectly diagnosed as hyperthyroidism during first trimester, right? Okay. Now this woman, we already know she's hyperthyroid. Um, we cannot say that she is controlled, honestly, because the TSH is very low and the T3 and T4 are above the normal levels. So what do you think is the best option here? Well, I am so proud of you. But you are convinced with the answer, or you remember the question from a book? You are convinced with the answer? Okay. Why you choose the propylthyroxine in the first trimester? Why not carpimazole? What kind of teratogenicity? Yes, this is a theoretical side effect of carpimazole and methimazole, which is aplasia cutis. Yes, this one. It's a rare side effect. However, we prefer to start with the propylthyroxine and then change to carpimazole in the second trimester because it has better control. Excellent. Okay, if I'm going to choose an agent during breastfeeding, what would be the best antithyroid drug? Carpimazole. I'm having different answers. Why I'm having different answers here? Which one is having a safer profile during breastfeeding? Because it reached the breast milk in smaller amounts. I'm not sure you do you remember this or not. I want to change the flow chart. One day I'm going to, but let me share the flow chart with you. Okay, we can remember it easily as follows. Which one is safer during the first trimester? PTU, right? PTU is safer during the first trimester and it's safer during breastfeeding. Yes. Okay. Carpimazole is better because we can reach a good thyroid profile with the lowest effective dose. It has a better compliance, it has better control profile. This is why we want to continue on carpimazole in the second and third trimester. That's it. Okay? If a woman is coming to you with symptoms and signs of hypothyroidism before pregnancy, she's now in the preconception clinic. What kind of tests you are going to order for her? no need, actually no need for antibodies. Thyroid profile is going to be okay and very enough. Okay, the follow-up, and I remember this was a recall. If you are going to do a follow-up, thyroid testing is needed when pre-pregnancy only, pre-pregnancy and early in the first trimester between 7 and 8 weeks only, pre-pregnancy early in the first trimester, again in the second trimester and third trimester, uh, everyone, pre-pregnancy in each trimester, postpartum, and choose the correct answer when you need to do thyroid testing. Actually, we need to do it pre-pregnancy between 7 to 8 weeks in the first trimester. And if she's taking a higher dose, we are going to do it 4 to 6 weeks until titrated. If she become if she become normal, then each trimester, then once in each trimester. This is going to be a hell of EMQ. The options will be very long, and it came before, by the way. Excellent, Dr. Kulsum. Pre-pregnancy is controlled once each trimester and then 6 weeks after delivery. Don't forget about early in the first trimester, 7 to 8 weeks. Don't forget about this one. This one is really important because this one is going to make us sure if she needs more dose or not. Maybe she's going to need 150 or more. Medication, again, medication. The best one in the first trimester, the safest one, is propylthiouracil. Second, third trimester, carfimazole. Breastfeeding, propylthiouracil. Okay, again, I'm going to repeat it again. So this was EMQ, and it was hell because the options were very long and so many options. Even if the pre-pregnancy levels were normal, yes, you should do at 7 to 8 weeks. Because the need for levothyroxine is going to change during pregnancy. No, propylthiouracil is not known to cause the aplasia cutis. Carfimazole and methimazole only. Don't forget about the early testing in first trimester. Pre-pregnancy testing is to make sure that this woman can get pregnant from the very beginning, because if she's not controlled, this pregnancy is going to be risky. She's going to be risky for miscarriage, right? She's going to be risky for placental malformations. We're talking about metabolism here. And the baby, if there is no enough thyroxine in the very early pregnancy, his CNS is going to be affected. Remember, the baby is depending on his mother thyroxine to make his own organs, all of it, especially speaking the CNS. This is why we have what was called before cretinism. So this is why we do the pre-pregnancy testing. Then the early in the first trimester testing is to get the starting point. Is this woman controlled? Yes, I'm going to increase the dose by 25 only. Maybe she would need more if she's not controlled. For fetal hyperthyroidism, yeah, in case, just in case, a woman is having Graves' disease and the antibodies cross the placenta and reach the baby. Okay? This is what we call fetal Graves' disease. You are not going to do anything. You are going to deal with the complications. If there is polyhydramnios or extra fluids in any of the cavities, you can take it out. But this is a very rare complication. This is one. Number two, this baby could have goiter also. So you should bear in mind that vaginal delivery is not going to be easy one. Would it could lead to obstructed labor. The polyhydramnios sometimes or the hydrops, I'm not going to say hydrops, if only he is having fluids around the lung and around the GIT, it can lead to lung collapse and GIT collapse, specifically speaking esophageal structures. So it's going to lead to more polyhydramnios because the baby is not swallowing the amniotic fluid. So in this case, you should interfere. You should take out uh, the fluids around the GIT or the fluids around the lung. But you cannot do anything else. Of course, we can control the mother. Hopefully, the antibodies are going to be less or no more antibodies are crossing to the baby. So the prognosis would be better. But those are like really uncontrolled cases. Okay, let's get back. So you are right. We are going to give her PTU and change it to carpimazole in second trimester. Excellent, excellent, everyone. Okay. Okay, I love this question. And it reminds me of cases that come in the exam. No much details and something that make your mind revolve. This one. Okay. So what do you think, guys? We are having this woman who is increasing shortness of breath. She's 28 weeks and respiratory rate is 16. Okay. Heart rate is 110. Temperature is 37.5. On auscultation, you hear a pleural rot. What can cause a pleural rot? Here, all of the following are differential diagnoses except, which one is the exception? The first one that should come to your mind is pericarditis and pneumonia. This is how we hear a pleural rot. Those are the most common causes of pleural rot. Pleuritis and pericarditis. We want except. Which one is the exception? Which one you are not going to hear a pleural rub with? No, actually pulmonary edema. No, pulmonary edema, not embolism. Pulmonary embolism, guys, gives us a picture like pericarditis, by the way. But pulmonary edema, there is no pleural rub. You can hear crepitation. You can have some sort of lower limb edema. You can have hemoptysis. You can have productive cough with pink sputum, not a clear hemoptysis, pink sputum. But pleural rub does not happen with pulmonary edema. Definitely it's going to happen with pericarditis, pneumonia, because pneumonia can cause pleuritis, pulmonary embolism also can cause a pleural rub for the same reason, pericarditis and pleuritis. This is a strategy question. And I know that they bring strategy questions. Okay, which condition would pose the highest risk of serious maternal morbidity or maternal death? Honestly, if this comes to the exam, they have every reason. Yeah, it happens. Mild pulmonary edema. But the scenario has nothing to do with the choices, by the way. They are saying that all of them are differential diagnoses except the edema. Diagnosis here is not the edema. Diagnosis here could be pneumonia, could be embolism, could be pericarditis. You got it vice versa. So here, what do you think? Which one is the highest risk? Okay, I have some of you who say Marfan syndrome with aortic root measurement of 4. Guess what? More than 4. If it's more than 4, then this is risky and she should not get pregnant. Repair tetralogy of Fallot, safe and can tolerate pregnancy. Wolff Parkinson White syndrome. This is one of the rarest type of arrhythmia that can happen during pregnancy, but still she can tolerate pregnancy. The one that pose the highest risk, yes, mechanical prostatic heart valve. Every time the mechanic valve wins. Why you have a fear of the mechanical valves? Yes, thrombosis. Yes, that's it. And it's much better than the animal origin one or the natural valve, but it poses the risk of thrombosis. This is the only risk that comes with mechanical valve. But it's durable. There is no need for a resurgery soon. There is much less rejection than the natural one. But we need low molecular weight heparin during pregnancy. Or what's better than low molecular weight heparin for mechanical valves? Warfarin, yes. Warfarin. Warfarin or Duax, actually. the direct oral anticoagulants. Not all of them, special types of them. But warfarin is, at least until now, it's a must for mechanical heart valve replacements. Low molecular weight heparin cannot work like warfarin in those cases. This is why most of the patients with mechanical heart valves are going to continue on warfarin throughout pregnancy. And then we are going to stop it before labor when you are going to stop the warfarin and replace it with low molecular weight heparin. 2 weeks before labor if you are having planned labor, or by 36 weeks. Yes, excellent. Both of you are correct. By 36 weeks or at least 2 weeks before planned labor or planned delivery. Then you are going to put her on therapeutic dose low molecular weight heparin. When you are going to stop the therapeutic dose low molecular weight heparin. 24 hours before what? Before induction? No, not before induction. 24 hours before spinal anesthesia. Spinal anesthesia, because I have a fear that there would be a hematoma at the site of the insertion of the spinal needle or the epidural needle. If the woman cannot tolerate this stoppage, I need her to be covered during labor as much as I can. Can I put her on another type of heparin until the active labor starts? Yes, that's it, the unfractionated heparin. So you can stop the low molecular weight heparin 24 hours before the assumed time that this woman is going to need a spinal or epidural anesthesia, and put her on unfractionated heparin during her stay in the hospital. Unfractionated heparin can be monitored, can be titrated easily, okay? We can have a control over it. And it can be stopped only 4 hours before active labor. So this is really great. I can put her on IV unfractionated heparin, right? Do good monitoring. She can have, once she got through active stage, I will stop it. 4 hours before active stage. So you can say by the time of induction, okay, you are going to do it approximately, and it's not your call alone, by the way. You should have the cardiologist opinion. What do you think, honestly, Dr. Pretty? Is it easier to deal with hemorrhage or with pulmonary embolism? Hemorrhage, of course. Yeah, pulmonary embolism is ICU case, and this woman is between life and death. So it's not our call alone, but theoretically speaking, okay, between errors, theoretically speaking, we can stop the unfractionated heparin 4 hours before the induction of labor. Or by the time of induction of labor, if she's really high risk. According to her case, whether we are inducing her for emergency or this is a planned labor or what. Okay, what about this one? A famous question. I promise we are about to finish. Okay, Dr. Pretty is saying that this is an anxiety. Um, I wouldn't say so, honestly, because the episode lasts for about 5 to 10 minutes. An anxiety attacks usually last for like 2 to 3 minutes maximally. And also, she's saying that it occurs roughly once a week. I'm thinking with you. Okay, she's saying also that it come on suddenly at any time. This is something also that can tell us that this is not an anxiety attack. There is no trigger. Another thing is she hasn't blacked out with them. So definitely this is not ventricular tachycardia. She does not have any heart problems. However, her father got heart attack by 55. This is young, by the way. So what would that be? Common is common. Go for the common reasons for such arrhythmias. I would go for ectopic beats. I would go for it because it is the most common cause of arrhythmia during pregnancy. However, ectopic beat does not last 5 to 10 minutes. Ectopic beats feels like hiccup, heart hiccup. I got them, and I feel them just like this, cardiac hiccup. I feel like someone hanged up my heart for like 2 seconds and drop it down. 2 seconds. Yes, yes, it is supraventricular tachycardia, typical case of supraventricular tachycardia. A tachycardia that lasts more than 5 minutes, recurrent, does not have any triggers. You should not pass out or be unconscious. Uh, there is no other symptoms or signs of notice. And yes, it is common during pregnancy also. What would be your first line of management? No. You suddenly jump for medication. There's something much easier to do. Yes, yes. How what we are going? Yes, Valsalva, excellent. We are going to teach her to do Valsalva maneuver. Yes, if she hold her breath and blow out, or tell her you can, when you feel you are having this speedy heartbeat, go to the bathroom and try to sneeze or try to perform like peeing, any Valsalva. This is going to control your heartbeat. It's going to slow down because we are pressing on the carotid, or we are stimulating the vagal nerve. So it's going to bring the heartbeat down. If this fails to control the heartbeat, what would be your medication? Adenosine? Yes, adenosine. Which one, which drug or agent is used for prophylaxis in next pregnancy? Let's say she wants something to be prophylactic for her. Yes, beta blocker, excellent. And beta blocker, by the way, is the prophylactic agent for many of arrhythmias during pregnancy. Yes, yes, dear. You know, guys, the table in arrhythmia in pregnancy, the drugs and the side effects, this is very important table, very important one. And most of exam questions come from this table. Like, for example, what would be the agent that cause fetal thyroid problems? This is a recall, by the way. Amiodarone, excellent. Which one can lead to small for gestational age, even with short use? With short use. No, again, amiodarone. Beta blockers can do this with chronic use. Okay. Which one is safe during pregnancy and breastfeeding? No, there is many. Verapamil is safe, adenosine is safe. Okay, you got the answer for this one? Okay, what would be the answer for this one, guys? Yeah, it's very easy one. Okay, let me ask you another question. This is apparently aortic dissection, right? Okay, if I told you that this woman is Marfan syndrome, what would be the most effective risk factor for having aortic dissection? The woman is Marfan and she's now pregnant. Excellent, 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 Dr. Preeti. She's very liable to have aortic dissection if her aortic root diameter is more than 4.5. Excellent. This was very old recall, but it's very important, by the way, and it's a safety point. It's a safety point in Marfan to make sure about the diameter of the aortic root. Okay, I wish this is, I'm not sure if this is the last one or not. No, we still have some questions. Okay. You can start from here actually because the the scenario is really long and in vain. Okay, so we have a moderate mild stenosis with a large left atrium. So what do you think the best management for her? She already had the commissurectomy, so don't choose it again. Okay, for a start, this woman is currently asymptomatic, so this is amazing. She can tolerate pregnancy. She's not on any medication. This is excellent. Okay. However, she still have a moderate mitral stenosis, and the left atrium is large. Do you remember what I told you? What we fear of when we have large atriums or something that can cause blood turbulence inside the atrium? Yes, so I want MDT, of course. I want to avoid bradycardia or tachycardia. Which one of them can cause turbulence more in the atrium? The tachycardia, yes, yes, excellent. Okay, and what about the echo? Monthly or bi-monthly in the three choices. So alhamdulillah, I'm not going to choose one of them. Excellent, guys. Excellent. So here we are. MDT, avoid tachycardia, monthly or bi-monthly echo. Anticoagulation, don't forget it, please, 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 please. Think about the turbulence inside the atrium and how this could be the reason why this woman is going to die. She's having a well-tolerated condition during pregnancy. She's well. Everything is good. But for some reason, this woman is going to have a tachycardia for whatever reason, and she's not covered with anticoagulation. And out of the blue, she's having pulmonary embolism. See? So here is our answer. Calmly, if you are having this long options in the exam, try to take a deep breath and ask yourself what I want to do. If this woman is hypertensive, I'm going to give her something to control the pressure. If this woman is having pain, she can have a painkiller. If she didn't have already the percutaneous valve repair, we can have it after 20 weeks of gestation. We prefer to do any operation in the second trimester, the second half of the second trimester. Okay? And finally, I'm going to think about her condition now. Does she need any supportive treatment now? Does she need oxygen now? Bed rest? They said no. They said she's okay, right? No symptoms, asymptomatic, and she's not on any medication. So, of course, I'm not going for the option with the bed rest and oxygen therapy. Okay, by the reason this is the cutoff for the pulmonary artery pressure, 50 millimeter Hg. Anything more than this woman, if it's pre-pregnancy, should not get pregnant. And if she is now pregnant, she should have beta-1 selective blockers. Okay, and of course, bed rest. to avoid pulmonary congestion and hypertension, of course. Okay, this one is easy. Come on, come on, come on, be quick. She's having repaired tetralogy of Fallot. Now she's having mild pulmonary regurg. This woman likely to tolerate pregnancy well. Yes, you are going to no, it's not in the guideline. I'm going to send you the table. Okay, remind me. I'm going to send you a table that contains each condition, cardiac condition, and whether it's safe or well tolerated in pregnancy or not, according to the European guideline. Remind me if I forgot. Okay. IPDs, I know that all of you have answered. I have seen your answers in Facebook. Okay, I'm following up your answers in Facebook, and mashallah, most of you know so much about IPD. I just want you to remember or make your own notes about which drug is safe, which one is unsafe, when to stop them, what are the precautions postpartum for the baby. What would be the precaution for the baby postpartum if the woman is taking biological agents during pregnancy? Or immunosuppressant? Is there any? Yes, excellent. This is what should come to your mind. No live vaccine for this baby for the first 6 months of his life. Yes, excellent. Mostly or approximately for most of the agents, you are going to stop the medications by 30 weeks. Some of them can be stopped by 32, some of them need to be stopped by 28, but approximately most of them are going to be stopped by 30 weeks. The only correct answer here is flare-ups of IPD are more common in the postnatal period. Okay, this woman here, this is the last question. She's having Crohn's disease, multiple perianal ulcers, anocutaneous fistula, currently well healed, being managed with oral prednisolone, infliximab by IV infusion. Are you okay with those medications? Okay. Um, do you want to stop the infliximab or something? Ideally, if you are going to stop the infliximab, sorry, when that would be? Yes, yes, approximately 30 to 32 weeks. I remember well. Okay, so here, what you are going to choose for her as intrapartum care? They are going to ask Dr. Mary, take care. They love the numbers. So if there is a table with numbers, like in infliximab, when to stop it, and celecoxib, and so on, remember the numbers. So here, this woman is having healed anocutaneous fistula. Are you going to recommend the vaginal delivery for her? Definitely, definitely, we are going to offer her elective CF. no instrumental delivery, no routine episiotomy. Okay, I'm going to do the episiotomy in case she insisted on vaginal delivery, and this would be very risky. Okay, and out of the scope for part two. So yes, elective cesarean section at 39 weeks is the correct answer. Excellent, guys. Why C is not correct? No, this is not the reason. Yes, excellent. Definitely she's going to need IV hydrocortisone in labor because she is on chronic prednisolone. But there is no need of continuous intrapartum fetal monitoring. No indication. This is why C is not correct. So if I'm having another option, maybe this can come as EMQ. So you can have elective cesarean section plus IV hydrocortisone in labor. This would be correct. Why B is incorrect? Again, there is no indication to avoid fetal scalp electrode. The baby is not going to bleed. He's not risky for any kind of hemorrhage. Right? Okay. If this woman insisted on having a vaginal delivery, are you going to convince her to have a CS, or you are going to refer her to the specialist or the consultant, or you are going to refuse her request, or what? We are going to counsel her about the pros and cons of vaginal delivery in her case. And if she insists, yes, respect her wishes. Do not refer. No, 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 do not refer. Respect her wishes and make sure that her delivery is going to be in a consultant-led care unit. Okay, you can do it. Do not refer her. No, no need to make her mind or convince or push her or anything. Just counseling and make sure that she's going to deliver in a consultant-led care unit, not in a midwifery unit, not in labor ward or labor suite, and of course not at home. That's it. Respect her wishes and tell her that she should deliver in a consultant-led care unit. This is very tricky in English. That's it. But, you know, sometimes there are some questions that you feel like in an English exam. Okay, well, I don't know how you beard me all this time, and thank you so much, guys, for being here today. I wish it was beneficial. Keep answering questions. Try to follow Dr. Madinji. She's posting amazing questions on the Facebook. Thank you so much. Thank you all. And inshallah, we are going to have another session regarding labor management with Dr. Rabah also. I think this week, so stay tuned. I'm not sure what is the timing exactly, but stay tuned in the group. Once the recording is finished, I'm going to upload it, inshallah. Thank you, dear. Good night, everyone, and take care. Bye bye.